So the question will pop up, then you answer it, then I'll give you the content related to that. But these are concepts you need to know for maternity, right? Very straightforward things you have to have at the tip of your finger, right? So, and let's review the order for a client at 16 weeks gestation with DVT. Which order the nurse should question, right? If you don't join, you see the game pin over there, you can join or you can type your answers. But this is how we have to participate. If you don't participate, I don't think it's fair. So which medication do you think is appropriate for this patient, and which one the nurse should question? Right, this is a straightforward question. The concept here is a pregnant patient should know if they have DVT, there's some medications they cannot take, like Coumadin and oral anticoagulations. One of them, as you can see, most of them, those that you have to take by mouth, they don't acceptable for these patients. They cannot use it. And therefore, those are the things you have to pay attention to, right? At the same time, they can take heparin. So this is heparin and nasoprene, test taking strategy. Tanzaparin, right? It's the same thing as that. And this is also an heparin. Even if you don't know the answer, there's 3 heparins over there. This is not an heparin. So that's your right answer. So these are the things, test taking strategy that you should be thinking. I give you 4 answers. There's 3 heparin. You should choose the other one. But the key concept is pregnant lady cannot take any oral anticoagulation. Most of them are PO. Dabigatran is an oral. At the same time, it's not good for pregnancy. The next one will be probably Coumadin, right? Warfarin. They cannot take it. So that's the concept. Second question. The code is at the bottom. You can see the code over there, 94114598. That's the code. And next case for a client with severe hyperemesis gravidarum, which finding is consistent with the disease process. Key concept. Hyperemesis gravidarum. What do you see in this patient? Very quick, thinking about it and decide which one do you think is acceptable. What do you see in this patient? It's very straightforward, right? Think about it. When your board give you this hyperemesis gravidarum, they just asking you about dehydration. Therefore, if you dehydrated, what do you see? Sodium 137 is normal. When you're vomiting, your potassium goes down, so you see hypokalemia, right? If you're vomiting and you dehydrated, your hematocrit goes up. Your hematocrit can go to like 15 or 14, so it's going to be high, not low. And since you're vomiting all your acid, you're going to have metabolic alkalosis. That is the concept. That is how to answer this question. Like I said, I'm just giving you straightforward concept design for maternity that you're supposed to know. So you see metabolic alkalosis. And client is in labor at epidural place. As soon as the infusion began, the nurse notes late decel. The nurse should do what? What should the nurse do? What should the nurse do? So go for the buzzword. Epidural place, you start infusion, there's late decel. What would you do? So another concept. You have to know if I place the epidural, the side effect of epidural is hypotension. So your blood pressure goes down. The patient had epidural placed, all of a sudden blood pressure is going down. You got to improve blood pressure. Pregnant lady on the supine position is good. Put them on the lateral position as much as possible. I know I got to give them fluid, but while they're still in the supine position, it's not going to be good. Therefore, the best position is turn them on their left side to take the uterus of the inferior vena cava and allow blood flow. The kid is having late decel is because of placenta insufficiency. Therefore, this is the right answer. Okay, as you can see, small concept that you should know. The game pin is here 4114598 if you want to play. But like I said, I have enough people to click forward. But that's the concept. And next cares for a client who has been ineffective at breastfeeding. Which action by the nurse is appropriate? Keyword: mother just had a baby, trying to breastfeed, having problem. What do you want to do? These are little things that you should be like able to give out quickly without thinking too much. The key concept is ineffective. And what would the nurse do? Mother cannot breastfeed. Are you going to call a lactation specialist to come and do your job for you? Or you tell the mommy to supplement with formula, right? Or to assess the position of the baby, or to notify the air care provider. If you call the air care provider, you say, well, just go do your job. Lactation specialist is okay, but fine. You have to know what is going on with the mother. Assess the mother and see if she's doing the right thing. She doesn't know how to breastfeed. Is the baby latching well? Is she giving the baby the way it's supposed to? So positioning, behavior, you even have to check for suckling. How are they latching? She's holding the baby. And if all of them is correct, yeah, you can tell the lactation specialist to come and help. Giving them formula is not important right now. It will prevent them from breastfeeding. They want to learn how to breastfeed. You should not stop. Encourage them to supplement it. The question is about breastfeeding. So answer the question related to breastfeeding. So don't choose this. This is the trap. Okay. So that's the right answer. Okay. That's the concept. I hope you got it. It's 30 seconds. You got to look at it carefully. After teaching the client how to wean the 12-month-old baby off breastfeeding, which client statement need intervention? I design it so that you don't have to guess yourself. If you see the right answer, you pick it. Once again, this is another concept, right? You taught the mother how to wean the 12-month-old. Which statement need intervention? Weaning should be done gradual. Abrupt is not good. This will lead to breast engorgement, and then you will have a bunch of pain. It's not good. You still have to breastfeed the baby, and slowly, as you wean him off, you add formula to it. So that's the way to do it, right? You should not give them too much cow milk. Then they'll get full and they will not eat solid food. You should not put the baby to sleep while they stay feeding. It's not good. So which one will need intervention? The question say intervention, and this way say I will not. So right answer is not to stop weaning abruptly. That means you should not cut the baby off the breast. You still give them breast and the formula slowly until you're able to wean them off. The nurse supervises a novice nurse who cares for a client in labor with ruptured memory. The nurse will intervene if key concept, intervention. If I see something, I will have to intervene. What is your buzzword? Focus on ruptured memory. If your memory rupture, what should you do and what you should not do? This is also a key concept. Every time they give you a question, it's a memory rupture. It's a couple of things. You're going to lose the amniotic fluid, right? There's going to be cord prolapse. You may have the cord will prolapse because of the fluid that is amniotic fluid, push it out. So it's a problem. It can cause the baby to undergo baby deceleration. All those things is not good, right? At the same time, you may have to look for the fluid. Mommy is going to have infection from it. The first thing is to prevent that. So allowing the mommy to work after the cord rupture, after the memory rupture is not the right thing to do, right? If you continue IV fluid, yeah, it's going to replace the fluid that is already gone, right? You should let the mommy void every 2 hours to make sure everything is, the labor is progressing, and you should assess for cord compression from the amniotic fluid that is lost. So these are the things. But mommy walking is not a good thing. Thus, the question said intervene. If you assess for cord compression, there's no need to intervene. Watch the answer choice and the question. If you read them wrong, you get them wrong. That is what your board does to you. I said intervene. If you check for cord compression, it's a good thing when somebody rupture. That's what you're supposed to do. The client LNP is 21st November 2023. What is the estimated date of delivery? The nurse should document, right? What do you think? This is something you should know, right? You already know. I'm trying to test you. You have 30 seconds. You should be able to calculate it quickly. And if you know the concept, it is easy, right? So what do? I said the LNP is that. So the first day is November 21st. Okay, you had some 30 days. You subtract 7 days from it, and you add a year. That's all. That's the formula. And you get that. Even if you don't know, sometimes look at the answers. So since you're going to add 7 days, it's not going to be 21 anymore, right? So at least 28. It should be not be and it should not be, it should be plus 7 days of the number they've given you, depending on the way they frame the question. So this is the yellow one, right? It's not blue. The client just delivered at 37 weeks. Temperature 100.3. Heart rate 70. Blood pressure 130/70, and large hemorrhoids. Client wants to eat. The nurse should do what? Baby, mommy just had a baby. And these are virals and everything. And she want to eat. What do you want to do? Do you let the baby, mommy eat or not? Concept. I want you to think fast. So that's why I give you 30 seconds. This is another traffic question. This is not February. This is within 24 hours. It's normal. Heart rate and vitals are normal. She just had a baby. A large hemorrhoid is suspected finding. She want to eat. Let the mommy eat. The vitals and everything is normal. No need to get a culture. You don't need to talk to the doctor. You don't need to assess uterine position. This is a trap. I intentionally put it there. You see the word assess, and he has uterine. Oh, you say, oh, I got to do it. Always is good to assess. It's not always good to assess. It does not answer the question. So once again, don't memorize answers. Don't memorize other things that people say you should. Is always. Always is never right. The question has nothing to do with assessing uterine position. She's ready to eat. Let her eat. There's nothing. These are the vital. If I want you to worry about the uterus, I will tell you she may be bleeding or something like that. So watch for, anticipate what they will ask you and use it to answer the question. And nurse is about to draw alpha fetoprotein level from a client at 18 weeks. What should the nurse tell the client? You see, 5 seconds to read it. Alpha fetoprotein, what does it mean? That's what the question is asking you. What does alpha fetoprotein mean? So what are you going to tell the mother? That I'm going to draw this. So alpha-fetoprotein, what is it related to? It can go up or it can go down. If it's high, it's neurotube defect or opening on the abdominal wall. If it's low, it's Down syndrome or other conditions. Therefore, it has nothing to do with pyloric stenosis, cardiac defect, or your bilirubin related to Down syndrome. You see where the concept is coming from? Master the concept. When they ask you a question, even in the case form, you know it. A postpartum client report about newborn scalp hematoma. Next assessment revealed caput succedaneum. The next you do what? Now, concept. What do you do when you see this? Caput succedaneum. Do you know what it is? Mother is worried about it. What do you tell her? Break down the question straightforward. What do you tell the mother? So this is a benign finding. It's due to trauma during labor. You have hematoma that crosses suture line. That is CS, crosses suture line. There's another one, hematoma. That does not cross suture line. This cross suture line. This goes away in 1 to 2, 3 weeks. It's a benign finding. You should not call the doctor. You should not massage it. Checking blood count is not going to answer anything. The baby is not bleeding. Just a hematoma from trauma. You should let the doctor reassure the mother that this is benign. It goes away 2 to 3 weeks. So some of the answers are trappy and they look convincing, and you're going to pick it, but they are not right. They don't answer the question. You have to know the concept. And as you're assessing a newborn diagnosed with Hirschsprung disease, which finding is consistent with it? Once again, one word. What do you see in Hirschsprung? If you don't know this is pediatric neonates, right? If you want more video, you check Adapt NCLEX, you see some videos there related to that. But what do you see? So, Hirschsprung disease. This is the problem. There is a ganglion along the anal sphincters in the anal canal. So the rectum get dilated because this area is not moving. The baby cannot pass meconium. The abdomen is going to get distended. The emesis is mostly bilious, right? Because it's past the pylorus and the belly is distended. They're not going to have blood think and mucoid, right? You know, this is interception. Projectile no bilious emesis is pyloric stenosis. Scaphoid abdomen is pyloric stenosis. The abdomen is distended. So this is what you see. You should not pick this projectile no bilious because the emesis is bilious. And let's care for a client in labor with shoulder dystocia. Which nurse action is a priority? This is also a concept you should know. Whenever you see shoulder dystocia, what should you do? What action should you do? What is your function? You put the mommy in the supine position. You apply fundal pressure. You do the Mark Roberts maneuver. Place the client in the left lower lateral position. What do you do? Concept. If you know this, it pop out like a candy. So what do you do? So this is also another concept you should know, right? Whenever you see shoulder problem, it's a bridge. You should never apply fundal pressure. Putting mommy in the supine position is not going to help. This is the maneuver. to be able to, you apply counter pressure to the suprapubic area, and the leg is flexed towards the chest or abdomen, and allow the doctor to pull the baby out. This is the maneuver. This is the maneuver. These other position, no. You have to know this by heart, right? Without not memorizing them. And next, auscultate fetal heart rate of 90 with the Doppler. And the maternal apical pulse is also 90. Which action should the nurse take? Once again, baby heart is 90. Mommy heart is also 90. What would you do? Concept, concept, concept. If you know it, it will pop out like a candy. What is the concept? There's no way fetal heart rate should be equal to maternal heart rate. This is the concept. If you don't know it yet today for the first time, you should know. Fetal heart rate is usually like 150, 110 to like 160. It can go up depending on what they're doing. But just remember, they cannot be equal to the mother. So when she listen and they find fetal heart rate of 90 and check maternal pulse 90, what she was doing with the Doppler was listening to the mother. Therefore, put the baby in the position that you can listen to their heart. And the maneuver is Leopold maneuver. That's the way to do it. It has nothing to do with cord prolapse. If I'm worried about cord prolapse, I'll tell you about rupture of the memory, premature rupture of the memory. These documenting this heart rate is not consistent. Baby heart rate of 90, baby is dying. That's really, really bradycardia. So think about it. Don't choose yellow because you know this is not normal concept, right? Telling the doctor, he will just laugh at you. Which statement by a pregnant client after prenatal teaching require follow-up? Okay, after I taught you prenatal teaching, what should you do? Right? I will continue to exercise. I will eat green leafy vegetables. I will what? Still play with my cat. And I'll watch TV with my leg laying on my back and my leg on the pillow. Which one? Pregnant lady should never be in a supine position. So sitting down on your back and your pillow, this is way supine. It causes hypertension. You can still play with the cat, but you should not clean their leader, right? That's the problem. Toxoplasmosis, right? Green leafy vegetables, you get some folate in it, right? And you can still exercise until you cannot. All these things, you have to know. Maternity is like that. This is the way maternity is. You have to know these little things. They ask you, and you feel like it's overwhelming. But this little thing is what I created the question. And next assesses a client at 26-week gestation. Which finding will cause the nurse to be concerned? The fundus is midway between the umbilicus and the suprapubic area. Exaggerated lordosis when upright. Fetal heart rate is 140, and the leg cramps are 90. Which one is worrisome? So this is straightforward, but it's a content you have to know, right? If you don't know, is the pubic symphysis, okay? Umbilicus is here. And then the xiphoid is here. Usually when it's here, umbilicus is like 20 centimeters. Just above the pubic symphysis, we have 12 weeks. The mommy is 26 weeks. So at 26 weeks should be above the umbilicus and in between the pubic symphysis, and xiphoid area. This said is between midway of the umbilicus and pubic symphysis. It's still here. Baby is not growing. That's bad. Fetal heart rate of 140 is normal. Mommy sometimes can get cramps unless they have itchiness. It's bad. Itchiness is bad. But having leg cramps is because of the fluid, uterus compressing on the IVC. And then lordosis is normal. In order to carry the baby, they have to hunchback and then support themselves, leaning forward, leaning backward with the uterus protruding out. So this is normal, and this is the right answer. And let's discuss symptoms of labor with the G1P0. Which statement by the client require follow-up? So which of this is not labor? Or they tell you and you don't believe it. So, and let's discuss the symptoms of labor. So that means which of these require follow-up, which of this is not true labor, right? I will experience lower back pain. Yeah, you move from your back to your in front of the abdomen. You may have some blood show, right? During labor, fetal movement decreases. It's not going to go up. Baby does not like contraction, so it goes down. I will notice a gush of straw-colored fluid down my leg. That is your water breaking. So this is all expected finding. So just pay attention and then know about this. This is all normal. This is the right answer. And let's provide teaching to a pregnant client who report of heartburn. Which client statement require follow-up? So she says she had heartburn. What would you do? Heartburn in pregnant lady, you treat them the same way, right? They should raise their head up 6 inches, a couple of pillow, right? They should avoid carbonated beverages. You give them too much gas. Dairy product is okay. It does not cause heartburn. Eating 6 to 8 hours a day means you're eating 3 large meal. You're supposed to eat small meal at a time. This is a traffic question, and so this is the right answer. If the question is hard, yeah, I intentionally made it that way. Simple, but you got to think about it to be able to answer. The client is found to miscarriage with no uterine contraction, no passage of tissue or cervical dilation. This is known as what? You have to know it, then you pick the answer. You don't have enough time. There's no contraction, no tissue coming out. The cervix is not dilated. What is that? You have to know type of abortion. If you don't know it, read about it. There's 4 types of abortion. There's more than that, but these are the ones you have to know. Which one is consistent with that, right? Mixed abortion, yeah. There's nothing coming out. There's no contraction. Mommy does not have pain. The cervix is closed. It's mixed. The baby is dead inside in the mother. Intrauterine demise. Threatening abortion, there will be some pain. There will be some blood. Complete abortion, everything comes out. Incomplete, that means not all the tissue comes out, a little bit, and you may need DNC. You see how you can break it down easily? But these are little things you should be comfortable trying to explain as much as possible. Incomplete means I'm going to pass something. If you pick incomplete, the answer to question say there is no passage of tissue. Incomplete means there's passage and you lost some. A client at 18 week gestation has elevated alpha fetoprotein. Actually, we talked about this already by different way. The nurse should expect what possible condition? Elevated alpha fetoprotein, what do you see? Elevated alpha fetoprotein, what do you see? I'll show you how to answer. This is test taking strategy, right? You know, alpha fetoprotein has something to do with neural tube defect or abdominal wall defect or Down syndrome, right? It's low in Down syndrome, is high in neural tube defect or abdominal wall defect. It has nothing to do with cleft palate, no tracheoesophageal fistula. Therefore, you left with this. And if it's low in Down syndrome because you're going down, I'm going to pick this, right? So and then care for several pregnant clients who meet the criteria for chronic hypertension. What is the definition? Don't bother yourself too much. Go with the keyword, concept, buzzword. What is the definition of chronic constipation? That means you have hypertension before 20 weeks. That's all. Then you look at the answer choice, which one is consistent with that? Make the question answering easy, right? Make it easy. So if you look at this, who has blood pressure before 20 weeks? This one say after 20 weeks. Wrong answer. This one say new onset of hypertension after 20 weeks. Wrong answer. This one say GP new onset at 25 weeks. Therefore, this one before. You don't even read this one. And so you can figure out the answers easily. I say all the time, to answer questions effectively, you have to come with the concept, write it down, make it the question easy, and you'll be fine. Client is 20 weeks pregnant with twins, right? She's not pregnant. She has newborn at 32 weeks. That's preterm, right? History of 3 abortion, right? What would you think? She's pregnant now. She has a baby at 20 weeks, and she has 3 abortion. How will you classify it? Straightforward. This one was quick, but it's 5 babies, right? 5 pregnancy, 1 now, 3 abortion, and previous one, right? And then no baby was born at 10. There's 1 preterm, which is 32 weeks, and then there's 3 abortion, and there's 1 living baby. So that's the way the twin baby is considered 1 pregnancy. G1 P0 client to present for prenatal care. LMP ended January 8th. Watch this carefully. What is the client's due date by Nagar rule? Remember, the LMP ended at January 8th, right? So this is the last day of the menses. The formula say you got to use first day. So this is key. Watch for this kind of question. So you have to subtract 7 days first, and then you're going to subtract 3 months, add the 7 days, and then your 1 year. This is how you solve this one. So watch for this. I just put it there. So I'm just teaching you here. I said the LMP ended. This is not the right day to calculate it, right? But it ended up being the same because you subtract the 7 days and then you add the 7 days later. But watch for that. It can change the date and it will not look the same. After teaching a group of pregnant clients, which statement by the client need immediate follow-up? So I will avoid IM influenza vaccine. I will avoid scooping cat litter boxes. We've seen this question, but I change it. I will avoid raw vegetables. I will avoid raw uncooked meat. Which condition, which situation the pregnant lady need immediate follow-up on it? When you're pregnant, you should avoid raw vegetables because then you can get sick from listeria, toxoplasmosis. Uncooked meat, the same thing, right? You can have a cat, but you can avoid their litter, which will give you toxoplasmosis. IM influenza vaccine is what? It's not a live vaccine. So that's what the mommy should get. They should avoid nasal flu vaccine. So avoiding this require intervention, a concept in disguise. Who should the nurse call first? Now your prioritization. I have leg cramp when I sleep. I have facial edema. I have urgency and frequency. I have shortness of breath when I'm going upstairs. They are pregnant. Who? Who should the nurse call first? So, once again, leg cramps is normal. Uterus is big. You're going to have urgency and frequency. Your uterus is big. If you're walking, you have shortness of breath. Facial edema is not good. It's preeclampsia, preset for preeclampsia. So we should intervene. I'll call you first. Which of the following is not a risk factor for uterine atony? Keyword is atony. Atony means it's too big. The uterus basically lack contraction anymore. It's not contracting the way it's supposed to. It's like boggy, it's huge, it's slow down, it's going to cause hemorrhage. So something, which of these is going to cause a boggy uterus? That's all. I can't teach you enough about how to answer questions and make it easy, right? And the questions say, not one of them. If you have a bunch of baby, uterus is going to get big, boggy. Advanced age has nothing to do with it. If you have multi-priority, you have had a lot of babies, yeah. And then if you use a lot of contraction, uterotonic like Pitocin, yeah, but because of the age does not make you to have atony. Make the key thing you're supposed to focus on simple, and you'll see like the question will become easy. Client receiving IV magnesium for preeclampsia, which finding indicate magnesium toxicity? There's a reason why I'm giving you magnesium is to prevent eclampsia. That means magnesium is a depressant. It's going to depress things. Which one indicates toxicity? Look at it. You see the way I approach it? It doesn't matter if you have 20 minutes. If you know how to break it down, 5 seconds, you pick the answer. I'm not saying you should rush when you're taking your exam, but this is like trying to teach you some keyword. I broke it down. Is a depressant, right? Tachycardia is going up. Reflexes is going up. Urine output is going up. I'm picking one that is going down. That is the concept to answer that question. Which nurse assessment finding in a client with preeclampsia is concerning? That means they are preeclampsia. What is going to be concerning is when we go into eclampsia. Or we go into HEP syndrome. These are the bad things. So which one of those tell you I'm no more in eclampsia? You see what I'm trying to do? That's the way to answer the question. Preeclampsia, your urine output is increasing, is good. Your urine output usually decrease. Tachycardia, right? Is consistent with what? Preeclampsia is not concerning. I expect that. If I see petechia, you've developed HEP syndrome. Yeah, your reflex plus 2 is normal. And so this is not good. You move from preeclampsia to HEP syndrome because you are petechia. And this is monitoring for client in labor. Which fetal monitoring pattern is the most concerning? you know acceleration, you know deceleration, you know variable deceleration, you know sinusoidal pattern. Which of them shows the baby is in trouble? So if you don't know fetal heart monitoring, you should know that acceleration is good. Early deceleration, let's keep on going. That checks labor progress. Variable deceleration, if you write your VCHOP mind, you know, variable deceleration, you're talking about cord compression, you got to check for it. Sinusoidal is severe fetal anemia. That's bad. It's the one of the worst. And therefore, that's what you should pick. A client at 32 weeks need emergency treatment for preeclampsia. Which prescription the nurse should question? You know they have preeclampsia, your blood pressure is high, they need emergency. She's 32 weeks. Don't pick a medication that you cannot use it in pregnancy. That is the concept for that question. And I'll give it to you. To answer this question, that statement is what you need. For medication giving, you have to know what medication you can use in terms of hypertension in pregnancy. Lipiodolol, adrenaline, levodopa is used in pregnancy. And naloxone is not good. Know some medication you should avoid in pregnancy. Your board will ask you. Your board will ask you. Your board will ask you. If you don't know, check Adapt NCLEX. What prescription the nurse should question in the management of Antepartum or preeclampsia? It's the same question but different content. That means what? Which of these I cannot use it when the mommy has preeclampsia and is still during antepartum time? That means the baby is still there as preeclampsia. You can have postpartum and preeclampsia. So this is antepartum. Pick a medication that does not affect the mommy's blood pressure too much, and it can lead to hypertension. Furosemide is bad. It can lead to dehydration, which can worsen placenta insufficiency. So we don't want to dehydrate the mommy and drop the mommy blood pressure too much from dehydration. But all of them can be used when mommy magnesium to slow you from getting what eclampsia. Adrenaline will help with the blood pressure. Methyldopa will help with the blood pressure. But furosemide is not a good thing. The client has tachycardia, heavy bleeding, 6 hours post C-section. What is the next best action? You can see I'm leading you to the right answer. She's bleeding 6 hours after C-section. What are you going to do? Are you going to call the doctor? Are you going to check a full vital, give them Pitocin, or check where the fundus is? There's little things you can do without no permission. And then what would you do if this lady is bleeding? You had a C-section. Yes, you should check the mommy consistencies of the fundus. Is it buggy? Is it like, where is it? It's supposed to descend or something like that. If it's not happening, yeah, you got to massage it. Of course, before you do that, you got to assess mommy before you give Pitocin. You can't give the Pitocin if you don't know what the uterus look like, right? If you call the doctor and said, okay, how does the uterus look like? And then checking the full vitals, mommy is still bleeding. A client 32 weeks admitted with severe preeclampsia. Which finding is consistent with the diagnosis? You go with the buzzword preeclampsia. What do I see? One protein, hemoglobin of that, headache, and then blood pressure of that. There's a word there, severe preeclampsia. How do you distinguish between the two preeclampsias? Is based on what? That's what the question is actually. Based on blood pressure. Both of them are going to have proteinuria. One of them is going to increase. This is severe. Hemoglobin is not going to affect it. Unless you have HEP syndrome, it's the blood pressure over 160 make you have preeclampsia, severe form of it. So watch for that. But all of them, mild and severe, will have headache. But the key thing is because it's hypertension after 20 weeks plus end organ damage, which is headache. But when your blood pressure is greater than 160 systolic, it's considered severe preeclampsia. Why do I say this question? Little topics that you should know by now. So if you're having problem with it, I know you know what to do. I would say you watch some of the videos, or you can go anywhere you watch. But if you don't know the difference between mild and preeclampsia, you got to work on it. Which finding is positive sign of pregnancy? Same thing. I can teach you this. You should know by now. Like there's different kind of pregnancy indication: presumptive, probable, and positive. Which of this is positive? And you have to know. They like asking this. Which one do you know this is positive, right? Positive means you have to like identify intrauterine baby. You have to use something. Ultrasound, listen to the heart, there's something there, right? Quickly, mommy is telling you. Pregnancy test, it can be positive, but it does not, because there are other things that can tell you that you're pregnant. Chadwick is the doctor is examining. I said positive, you examining using an object to look inside the uterus. Chadwick does not look inside the uterus, right? 37 weeks in labor, new severe headache, blurred vision, epigastric pain, blood pressure of this. And what should the nurse do? She's 37 weeks, is in labor, now has a headache, blurred vision, and organ damage, and epigastric pain. The blood pressure is too high. What do you think? What will you do? You call the doctor, you give them furosemide, you prepare them to deliver, or you monitor for fetal heart rate. So there's a big change, right? This looked like really big. She has severe headache, blurred vision, epigastric, close to like she getting Ep-like syndrome. Yes, we'll prepare to deliver, but before we do, we got to make sure the doctor know about it. We got to monitor fetal pattern. We do not give the baby laces. If we need magnesium, we got to give, but we got to let the doctor know. It's a severe change. This will kill the patient. And let's provide teaching to a client at 15-week gestation post-cerclage. Which client statement require follow-up? Once again, concept. If you don't know what the cerclage is, please read about it. Also, find a video on YouTube or wherever you get your resources. But you have to know what cerclage is. For OB, what do you do? What teaching you provide? And when should they go labor? That's all. If you write the things I'm saying, you should go read about it. You see, you know everything about OB. It's just topics that they will try to trick you. So class is people who have incompetent cervix. When you put a suture and sew it like that, these sutures stay there until 36 to 37 weeks. We admit them before they go labor. So you teach them to before they go labor, right? They don't need to check the sutures or anything like that. If they have signs of labor, they should let you know, right? We don't remove the sutures. You stay there to like 36 to 37 weeks until you have to. And this, even if you don't know, Look at blue and green. They're contradicting each other. This is how you answer question. This one says suture will be removed at 30 weeks gestation. Suture will be removed before onset of labor. If I don't know, I see these two things. Why are they talking about this? I will ignore the red and yellow, but these two are trying to say opposite thing. One of them is right. That's how you answer question. And then to pick the right answer, you know that they have incompetent cervix. You don't want them to have deliver the baby anymore. So they should stay in until the baby is mature. Which of the following is not a risk factor of cervical cancer? Okay, so this is the key. It's one of the common cause of caused by HPV, right? And this is very common STD. Over 90% of the people have it, but nobody knows about it. Side effect is really bad. Which of the common risk factors causing cervical cancer is what? Tobacco, HPV is due to having intercourse before the age of what? 18. This is true. Is a risk factor. Is if you have intercourse before the 18 years old, there's a risk of having HPV. This is why we have vaccination for young kids before they turn 18. Smoking is also a risk factor for cervical cancer and multiple sexual partners because of the exposure and previous exposure of a lot of multiple STDs is a risk factor. So the only thing not is yellow, but don't forget tobacco, multiple sexual partners, sex at a younger age. It's a risk factor for HPV, and HPV is a major risk factor for cervical cancer. The fetal position documented by the nurse is representative of the image below. So what position is this? Is it left occipital posterior, left occipital anterior, right occipital anterior, or right occipital posterior? Do you know how to name this based on the diagram? I know you know because you watch Adapt NCLEX, but if you don't know, review it again. You should be able to answer this. And there's easy way to go about it, right? Remember, if the baby, if you look at the image is gone, but the baby is touching. This is if you're facing the mommy, this is the right, and this is your left. Your left is the mommy right, right? So, and your left is the mommy right. So the baby is touching mommy right. So it's the right side. He's using the back of his head, his occipitals, and he touching the back side of the mommy, posterior. This is the right occipitals posterior. Right occipitals anterior means on the right side, but baby is touching here like that. Left occipital posterior is the left side of the mother using the posterior aspect and touching the posterior aspect of the baby. And then this is the left anterior occipital, like that. The transverse one is the axial spine here. But these are the position you should be familiar with. What is the most common complaint the caring nurse should anticipate for a client in labor with this fetal position? This is the same thing. You have to read it first. This is like said, this is the on the right side of the mother. So right occiput posterior. What would you see when the mommy has right occiput posterior? What do you think she's going to complain about? That's what the question is asking. So when a baby is touching the posterior aspect of the mommy, every time mommy contract, she's going to have severe back pain. So the way to avoid that, you provide contraction to the back. This is I've given you 3 questions the NCLEX will ask you. First of all, recognize that right occipital posterior is not a good position. What kind of signs and symptoms mommy is going to have? Back pain and contraction. What kind of intervention you should do? Contraction. 3 good NCLEX questions. If you know it, you should be golden. For a client in labor, a sudden cessation of contraction, loss of fetal station, abdominal rigidity is associated with what? Is a definition. Is this abruption? Is it accretor? Is it a rupture? Is it a previa? The key word is loss of fetal station and cessation of contraction. In abruption, there's still contraction. Accretor, contraction is occurring, just bleeding. In previa, there is no cessation of contraction. Things are still going on. This is rupture. If you don't know it, check maternity, or you can subscribe to Adapt NCLEX, join our YouTube membership. You get the easy way to master content. I call it 7 days NCLEX challenge, or you can just join my on-demand website, and it's on https://www.adaptnclassreview.com, and then most of the lectures I use for the crash course, and you can learn a little bit of content and be confident for your exams. But you should be able to know the difference between this. And the last question: which vaccination order for a client at 8 weeks gestation? The next question. Why did I ask this question? I can rewrite this question in a different way. Which of this is a live vaccine? Because I'm going to question it, because I know the lady is pregnant. You see, I know the patient is pregnant, and if I have to question it, it has to be a live vaccine. If I have to look at it, which one is a live vaccine? Then you pick your answer. Don't let the NCLEX people take control over you when they ask questions, right? If you don't know, we have something we call TDAP. You see, you cannot put one vaccination when one is live and the other is not, right? That's why MMR is a measles, mumps, rubella are all live vaccine. You put it together. These are non-live. So you have diphtheria, right? Tetanus and pertussis. So this, that, and that they are in one. We can give it at once. HPV is a live vaccine. This is Adapt NCLEX. Thank you for watching. I know the answers are very quick. I don't want to give you enough time. I want you to think about it. But these are little. There's a reason why I said it that way. Like, you read a question, you should know what answer you're going to pick, not to be like guessing which one. Think about all of them. If you need some content, I encourage you to find some place and then try to master it, before you go and take an NCLEX.